Drug-coated balloons are a novel therapeutic option in certain situations of coronary artery disease. An established use of drug-coated balloon is for in-stent restenosis of both bare metal and drug-eluting stents. Drug-coated balloon transfers anti-proliferative drugs into the vessel wall during single balloon inflation. This is done by means of a lipophilic matrix. The advantage over drug-eluting stent is that there is no permanent implant. Drug-eluting stents have the disadvantages of neoatherosclerosis and stent thrombosis. Even temporary implants like bioresorbable scaffolds have elevated thrombotic risk. Other potential indications for drug-coated balloons are in small vessel disease and in those with high bleeding risk with limitation on the use of dual antiplatelet agents. The lesions are prepared by optimal angioplasty prior to delivery of the drug with a drug-coated balloon. Optimal lesion preparation may be assessed by angiography, intravascular imaging, or physiology. If the lesions cannot be prepared adequately with balloon dilatation alone, ablative procedures like rotablation, laser, or orbital atherectomy may be needed. Stent implantation may be needed if the results are suboptimal after lesion preparation. These include dissection and significant recoil. Sometimes stenting may be required as a bailout after the application of a drug-coated balloon. Bare metal stents may be enough in such situations to scaffold the vessel. No post-dilatation is done after the use of drug-coated balloon as it will disperse the drug which has been delivered. DAEDALAS study was an individual patient data meta-analysis of 10 randomized clinical trials comparing paclitaxel-coated balloon angioplasty versus drug-eluting stenting for the treatment of coronary in-stent restenosis. The analysis showed that in patients with coronary in-stent restenosis, repeat stenting with drug-eluting stent was moderately effective than angioplasty with drug-coated balloon at reducing target vessel revascularization at 3 years. Composite of all-cause mortality, myocardial infarction, or target lesion thrombosis was similar between the groups. The rates of individual endpoints were also not statistically significantly different between the groups. Drug-coated balloons are similarly effective as drug-eluting stents in reducing revascularization for in-stent restenosis of bare metal stents. Patients with drug-eluting stent in restenosis are a selected high-risk population with primary failure of local drug delivery by the stent. The potential relative efficacy of drug-coated balloons versus drug-eluting stent may be different as the underlying tissue substrate is different. Neointimal hyperplasia versus neoatherosclerosis. Though the initial drug-coated balloons used taxane compounds like paclitaxel, sirolimus-coated balloons are also now available. SABRE trial with sirolimus-coated balloon was a first-in-human study which showed excellent procedural success and 6-month late lumen loss in line with other stent-free options for in-stent restenosis. DEBUT trial evaluated the role of drug-coated balloon in de novo coronary lesions in patients with high bleeding risk. It was a single-blind, randomized, non-inferiority trial involving 208 patients. Vessel diameters ranged from 2.5 to 4 mm. Drug-coated balloon was shown to be superior to bare metal stents in patients at bleeding risk. Those with ST elevation myocardial infarction, bifurcation lesions needing 2 stents, in-stent restenosis, flow-limiting dissection, and those with more than 30% recoil after target lesion predilation were excluded from the study. Drug-coated balloon angioplasty with rescue stenting versus Intended stenting for the treatment of patients with de novo coronary artery lesions was an open-label, randomized, non-inferiority trial. The trial concluded that in patients with de novo non-complex coronary artery disease, a strategy of drug-coated balloon angioplasty with rescue stenting did not achieve non-inferiority compared to intended drug-eluting stent implantation. The primary outcome assessed was the device-oriented composite endpoint, which included cardiovascular death, target vessel myocardial infarction, and clinically and physiologically indicated target lesion revascularization. It was an intention to treat analysis at 24 months of follow-up. Drug-coated balloon angioplasty of the side branch during provisional stenting trial evaluated patients with simple and true coronary bifurcation lesions. Main vessel stenting with a drug-coated balloon for the compromised side branch resulted in a lower 1-year rate of the composite outcome compared with a non-compliant balloon intervention for the side branch. Primary endpoint assessed was a composite of cardiac death, target vessel myocardial infarction, or clinically driven target lesion revascularization at 1 year of follow-up.